Hello, I'm Bill Shergy, a practicing rheumatologist in Huntsville, Alabama, and I'm at the ACR. I just left a session on guidelines for handling DMARDs and biologics for elective surgery. I thought it was really a very nice effort at the guidelines, and they were summarized quite well. It was a collaboration of the ACR and the Academy of Hip and Knee Surgeons. Also involved were a group of patients who had their input as to what they were more concerned of, a flare of their disease or an infectious complication. They advised the physicians on the voting panel, but they did not have a vote themselves. And the guidelines as they came through certainly were based on as much literature as could be found, but that was one of the problems. There's not a great deal of literature on this topic. The one area that had the best literature was what to do with oral DMARDs, particularly methotrexate and leflunomide, and the recommendation there was a very strong continue therapy through the surgery. This not only reduced infectious complications, but this reduced complications of the surgery and also reduced flares of rheumatoid arthritis, leading to a better patient outcome. The results were a little less clear for other agents. The biologics recommendation was to hold therapy for one full treatment cycle prior to surgery. That is, if you're using Humira every other week, to do the surgery in the third week. In regards to starting therapy afterwards, the recommendation was approximately 14 days after surgery when the patients should be starting their healing process and be quite clear that there's no infection. There was strong emphasis on coordination with the surgeon and the rheumatologist involved in the patient's care. And there was also a look in this study at patients with lupus, but here the data was even much less firm. And the recommendations here were if you had mild to moderate lupus, to continue therapy with agents such as Cellcept. However, if the person had severe lupus, that was the recommendation to hold that agent prior to surgery because of possible risk for infection. They did admit some strong concern with this because of flares being much a bigger risk to the patient with lupus than they may be with RA, that it may be organ failure or even life-threatening. So that was the summary on those agents. The last bit that was covered was on steroids. The recommendation for steroids was evaluated to see if continuing baseline dose versus giving stress doses of steroids for the joint replacement. And the recommendation here was to continue the baseline dose, that there did not appear to be any benefit of doing a stress dose of steroids. There was no change in outcomes, there was no hypotension or other deleterious effect to the patient. So that was the summary of a very exciting session, and this is Bill Shergy thanking all of you.